So the second key recommendation is all patients who've had a TIA or a minor stroke do need antithrombotic therapy, and if it's a non-cardiac source, antiplatelet agents are the drug of choice. I don't think the critical issue is which antiplatelet agent. The critical issue is to start an antiplatelet agent. If you're starting aspirin for the first dose, patients should be loaded with aspirin, which is basically a full aspirin tablet. If you're starting with clopidogrel, they should be loaded with clopidogrel, which is about 300 milligrams. This is to get the antiplatelet effect up to speed immediately. And if you're using the combination of aspirin and extended-release dipyridamole, then you should also, on the first day, give an additional aspirin tablet to make sure that the platelet binding sites are fully saturated. The selection between aspirin, clopidogrel, and the combination of aspirin and dipyridamole is based on side effect profiles, whether the patient was already on a drug, and on cost to the patient and patient preferences. So once a patient's had a TIA, they should be processed, seen, and dealt with in an efficient fashion. Now, the section of emergency physicians and emergency medicine has established a standardized order set that's available in all emergency departments, and the purpose of this is to provide a stepwise, organized approach to TIAs to ensure that the appropriate studies are done in a quick and efficient fashion. These order sets are available online. They include an order set for TPA if you're treating an acute stroke, and so I would urge you to look at these resources as well. This package has gone out to emergency physicians across the province and should be available in all emergency departments. So for the treatment of acute stroke, we basically have two effective therapies. One is a pharmacologic treatment, which is TPA. Intravenous TPA is the only proven and established treatment for acute ischemic stroke. Fortunately, the therapeutic window for TPA has been expanded a little bit to 4.5 hours, but I think the real key issue is here is that the sooner you give it, the better. So our third recommendation is that for patients, eligible patients who've had an acute ischemic stroke, they should receive TPA according to guidelines as soon as possible within that 4.5-hour window. And this rather Dali-esque looking picture is designed to demonstrate that time is brain, and of all of the organs we have in our body, the brain is the one that is most exquisitely sensitive to ischemia and loss of continuous blood supply. And as an example of that, cardiac arrest, which is a global ischemic condition, if you think about it, the cardinal manifestation of a cardiac arrest has nothing to do with the heart. It has everything to do with the brain. The brain stops functioning within seconds. You fall down, you collapse, and you're very still. That's how quickly global ischemia hits the brain. Fortunately for focal ischemia, a stroke, by virtue of collateral circulation, we do have a little bit of time to reverse the damage or to minimize the damage, but it's a slippery slope and the tissue dies quickly. This slide is a meta-analysis of the absolute benefits of TPA over time based on the TPA clinical trials. And so we see that the really sweet spot of acute treatment is to treat everybody within 90 minutes. And there's a 2.5-fold increase in absolute cure rate if we do that. Now that's a challenge. We may not even see patients within 90 minutes, but the whole focus of acute stroke therapy right now is to minimize every possible time element. That involves public awareness, so they recognize the signs and symptoms of stroke. They call 911. They get delivered to a stroke-capable hospital, or at least get rapidly triaged in their local hospital and transferred to a stroke-capable hospital. And once they hit the stroke hospital, the door-to-needle time must be kept to a minimum. So there's all these little time elements, each of which we have to tighten up and reduce so that we can treat patients as soon as possible after their event, preferably within the first hour, 2 hours, 3 hours, but if necessary and if required, up to about 4.5 hours. That's for conventional intravenous TPA. So now, stroke management, once they've been admitted to hospital, they may or may not have received TPA, but general and supportive care of stroke management is the second element that's been shown to improve outcomes and reduce morbidity and mortality. It's not rocket science, but it is careful attention to these little details that pays off time and time again. Of course, patients have to be monitored. We want to keep their temperature normal. Hyperthermia is destructive to the brain following acute stroke. We have to make sure that they're not hypoxic. Elevated blood sugars increase the stroke damage, so we try to keep their blood sugars within normal range. It's uncommon that we have to manipulate blood pressure early following a stroke. In fact, the thresholds for intervening and lowering blood pressure are quite generous. We still really don't know what the optimal blood pressure is following an acute ischemic stroke, but for the most part, for non-hemorrhagic strokes, you don't have to intervene in the first 24 or 48 hours. The mistakes that are commonly made time and time again are that patients aren't mobilized early enough. They are at risk for aspiration pneumonia, so they need swallowing checks if appropriate, and catheters are left in too long and they get urinary tract infections. So our fourth recommendation, and this is based on really solid evidence, is that for optimal management, patients should be admitted to a stroke unit. This has been shown to reduce morbidity and mortality in stroke by about 30%. In other words, it's as effective as TPA, although they should be used in combination to get the benefits of both. The definition of a stroke unit sort of depends on your hospital. It may just be geographically cohorting your patients onto a single ward so that you can have stroke care pathways and skilled nursing care, or it may be a full-on neuro ICU and stroke unit with integrated rehab services. I think the definitions will vary depending on your geography. So the second key, I've talked about carotid disease as one of the things that must be identified early because it does change management. It means the patient needs an operation. The second thing that Ron has mentioned already is identifying the patients who need a different anticoagulant or a different antithrombotic agent. And those, for the most part, are cardiac source embolus, and the biggest cardiac source embolus is atrial fibrillation. By now, I'm sure you're all aware of the CHADS-2 scoring strategy. This is to identify high-risk patients who are more likely to benefit from warfarin versus aspirin, and it's an acronym, of course, for congestive heart failure, hypertension, age, diabetes, and previous stroke or TIA. So it turns out if you've had a stroke or TIA, it's almost an automatic that you have a very solid indication for warfarin. So our fifth recommendation to you is that consider all patients with atrial fibrillation for antithrombotic or anticoagulant therapy, and the selection of which agent, antiplatelet versus an anticoagulant, will be based on risk stratification as well as risk and benefits and patient preferences. So this is the CHADS-2 score. Low-risk patients may be treated safely and effectively with aspirin for the most part. High-risk patients require dose-adjusted warfarin.